Afferent stimulation influences central nervous system processing. Stay tuned because today you will discover applications for vestibular and autonomic dysfunction, chronic pain, concussion recovery, and cognitive improvement. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions to get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Tatiana Habanova is a board-certified chiropractic neurologist and functional medicine practitioner with 27 plus years of experience in neuroperformance, functional medicine, and concussion recovery. She founded Palm Beach Brain Center to help individuals restore cognitive vitality, navigate metabolic processes, and build long-term neurological resilience through personalized brain-based care. Today, she'll be sharing with us sensory neuromodulation and neuroplasticity, emerging applications in neurological rehabilitation. Dr. Habanova, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
All right, well, today I'm going to be presenting a little bit on some emerging applications in the neuro rehab space, predominantly using sensory neuromodulation to enhance and perhaps correct any neuroplastic changes that have occurred. As Dr. Krista Burns mentioned, I am a board-certified chiropractic neurologist and the founder of Palm Beach Brain Center, and I'm just very happy to be a part of this presentation today. So let's go ahead and talk a little bit about what neuroplasticity is, and really actually a neuroplasticity problem that exists that maybe sometimes we don't always think about because the brain is always changing. I'd actually like to start with a little case study that I'm going to be sharing a little more detail as we get further along about a patient of mine that I've started working with for several months, who came to me predominantly for tremor-like presentations, a very Parkinsonian-like presentation. And we've done a variety of different things to improve her whole overall health from a functional neurological perspective, a functional medicine perspective, and things were improving on many levels. And the tremor did improve, but it didn't quite go away completely. And it was interfering with things such as her just holding her phone, and it just, anything weighted in her hand would just, start to really increase that tremor. Or recently had a grandchild, and she, was concerned that maybe she'd just be too shaky holding the baby and maybe drop it or something like that. So it was really impacting her on many, many levels. Those are just a couple examples. And interesting enough, just being able to use a wearable neurotechnology within moments, that tremor stopped. So it's a very interesting case that I'll present a little more detail with, but it's interesting to ask ourselves why, when applying something to the skin, we have some immediate changes from the brain. So let's talk about the neuroplasticity problem. And what that is that neuroplasticity isn't necessarily always good. So, I mean, we assume that it's going to be that way. We'd like for it to be that way. We certainly make our neuro rehab goals that way. But sometimes the brain learns the wrong lesson. And one of the big misconceptions is that neuroplasticity always has a beneficial outcome. And that's not always the case. For example, at times when we see patients with chronic dizziness, even after tissues have healed, or the persistent concussed patients who are having lingering symptoms, chronic pain patients have, significant alterations to pain pathways despite no new injuries or flares that might be occurring. So these are all examples of maladaptive neuroplasticity. So today we're going to talk a little bit about what that is and what we can do about it. So again, just briefly, neuroplasticity is just the brain's ability to make a change based on its experience and whatever that experience might be. Adaptive plasticity, of course, is what we're always trying to aim for when we're trying to promote healing recovery, or we're just learning something new in life, maybe taking up a new hobby of some sort. And there's a variety of different mechanisms that are utilized to help strengthen those networks and pathways from all the way down from neurotransmitters and structural remodeling of the brain itself. Real world examples where we see these things, of course, is in stroke rehab, for example, but also in any type of skill acquisition. So really being able to allow those plasticity of the brain to change into favorable outcomes. So as we know, sometimes maladaptive plasticity does occur with patients when they have any type of trauma. And, even when appropriate healing is taking place, sometimes not all those connections occur the way we want, and the outcome is a maladaptive plastic event. So here again, we can see that when there is trauma or we're reinforcing a dysfunctional or a harmful state, then that obviously is going to be linked up and wired together. And a lot of the mechanisms are that those inhibitory excitation pathways are just not in balance. So we've got to be looking at that from that molecular level, that we're starting to get changes structurally that are not favorable. And then we're going to start having compensatory patterns along the way. So we see this, of course, with chronic pain being one of the major examples here, where we do have that altered signaling, and then we have almost a permanent reorganization of sensory pathways or motor pathways. So therefore, they're feeling pain even when there's no painful experiences. Another common example, of course, would be like phantom limb syndrome, where there's an amputee, a limb has been amputated, but yet there's still signaling into the brain despite that body part not physically being there. Even unhealthy habits or addictions. So repeated behaviors is what I'm trying to get at. Even if it's, as I say, substance abuse or anything persistent, persistence avoidance behavior. You say you want to go to the gym or you want to start a project or something like that, and you're not doing it, you're not doing it, you're not doing it. Anything of that nature, of course, is just going to wire those neurocircuits. And especially if it's repeated and it's deeply ingrained, now we unfortunately might have these habitual patterns that might be difficult to break. So when the brain learns the wrong lesson, basically maladaptive plasticity, and I like this slide because it really shows these two pathways in what we need to be thinking about as clinicians. This is what's happening not only on the molecular level, the cellular and structural level, but always also into the network level. And we can see where things are going right, what needs to happen, and when things aren't going the way we'd like for them to go, how that's going to lead down that maladaptive plasticity pathway. And most of us as clinicians are usually being encountered with patients that already have those maladaptive changes. So again, neuroplasticity isn't necessarily inherently good. It's that, we have to be able to guide this process as best as we can when these situations, first occur. And even if it's been years down the road, how can we, re-navigate that situation? So a statement that kind of really hit home for me was a clinician saying to me that patients don't just suffer from damaged neurons, that the actual neurons are a problem. They actually suffer from maladaptive adaptations. And that just really kind of changed the way I viewed a lot of things. So let's go into the neuroplasticity shift and how perhaps a traditional view of neurorehab, which is predominant for many, many years, and moving into perhaps this newer emerging view of how we can approach neurorehab and basically undo maladaptive neuroplastic changes. So the traditional view here on the left side of the screen starts with behavior, where it's like, okay, we don't have the outcome we want. Let's say you're practicing a new skill, or you're working on balance or memory, or your jump shots, or whatever the case is, and you first attempted and you're not hitting the bullseye. But with practice, so changing your behavior, let's say just continuing to try to get that dart right into the bullseye, over time, we assume the more you practice, the more you practice, the more you practice, eventually there'll be changes at the cortical level. And then of course, they'll dwindle down right down into the actual neurons themselves and at those synaptic junctions. And in my understanding, and when I talk to other clinicians, is this general sense of neuroplasticity still being occurring at the neuron level. So it's just like, as long as one neuron kind of connects to another neuron, a lot of times you'll see little video clips of one brain cell, and then all of a sudden it kind of grows over there and it makes a new connection. And we're like, yay, all of a sudden there's this outcome, but it's not really the whole picture. And emerging thoughts in this field are moving now into a network view of making neuroplastic changes, and this idea, this perturbation occurring, so that the brain is obviously very dynamic, very interconnected, but that we need to really consider that neuroplasticity exists at multiple levels. And so we can see here on the right side of the slide that we can make neuroplastic changes on the molecular level. We can make changes that are occurring, in the gene expression with protein synthesis, et cetera, and some of the key molecular players that you see there in BDNF, of course, and some of the neurotransmitters. That's going to translate into the cellular level, at the circuit level, and then large scale networks. And then finally, there's going to be a behavioral change. So here we have behavior at the end versus the beginning. And at the very bottom, I really like the little bit of this spectrum showing here that if we add these perturbations, and really all the perturbation is just really introducing a control challenge that forces the nervous system to reorganize. And to think about as you're creating your interventions towards the patients, figuring out at what level of these 5 levels, where can you include some of those control changes as perturbations. And so I think it's just nice that this diagram at the bottom is that behavior is the final expression of biological adaptations. So really being able to recognize that every neurointervention is actually an attempt. If we really think about what we do and look at it through this lens, we actually are creating these little perturbations and trying to alter dysfunctional neural networks and then provide or promote, these adaptive reorganizations that are actually occurring on multiple levels. So I think we just need to kind of recognize that there's a lot going on and there's a lot of opportunity as well for change on many levels. So the 3 pillars of brain recovery, if we're looking at it from the molecular perspective and working our way through to the behavioral change, is that we've got to really double down on 3 major aspects. So those are error processing, the sensory context, and then excitability of the landscape. So thinking about your interventions, you're going to want to add another level of thought to this and leaning into the brain learns from prediction errors. This is super important, and we want to be able to double down on the neurocircuitry that is already responsible for that, for example, like the cerebellum. And being able to allow patients the opportunity to make those errors, and that the errors are actually where the intervention is, and that the success in a particular exercise, a neuro rehab exercise that you're doing with the patient in the clinic or at home, is that the outcome isn't about getting it right every time or doing it perfectly, which is what the patients are kind of putting the pressure on for themselves, and to release that and say, actually, what we really just need to do is we have an objective of what we want to achieve. We want to hit the bullseye, for example. Let's go ahead and allow the brain to make some of those error processing components for us. All we have to do is just go for it. And then that's excellent right there. Of course, we know that the nervous system also is very integrated. So we want to think about all the different ways the nervous system receives information in its environment. So we want to be thinking about vision, touch, proprioception, vestibular input, the environment itself, the motivation. All of that actually reshapes recovery too. So we really want to become multidimensional if we can, if it's not too much for the patient, to be thinking about how we can keep adding more sensory context to the work we do. And I think most importantly, although I think all these are important, but the most important is the excitability of the landscape that I find for me, that recognizing how the patient comes every day to the clinic and this ability for their brain to be ready to have any fluctuations or changes occurring is super important. And so really looking into what we can do to almost prime the brain for neuroplastic opportunities for when they come into the clinic. What can we do besides just throwing a bunch of different exercises on them or perturbations that we're trying to do, but literally, set them up for success. And so neuromodulators, can be very helpful in this case. And we're going to talk about certain things that might also be of value. All right, so let's go ahead and move right into the somatosensory component. I'm not going to spend too much time on this because I'm assuming everyone should know this material by now, but we just want to bring this fresh to the mind that the somatosensory system, contains our cutaneous receptors as one component. The skin is heavily innervated with so many receptors. In fact, just a quick little Google search, billions of sensory signals are sent to the brain every second. So this is obviously an underutilized or untapped gateway that we should be considering more. So of course, we have all our different types of receptors that live in the skin that provide the different types of information. And we really want to, again, key into this idea of utilizing, if you think about repetition and intensity being important in one of the 10 principles of neuroplasticity, what better way than to maybe have, one receptor just give low level information that's like getting one email. Imagine you got a billion emails a day. It would be overwhelming for us. But for the brain, it would be giving it a lot of context and a lot of, like I always say, meat on the stick, a lot of juice. So again, the error processors and various things that are happening are going to also sort through a lot of that. So we do have to just keep providing that information, that sensory information. If we look a little bit here again at some of our pathways that we know, we have our DCML pathway, we also have our spinal thalamic pathway, so we can see how they're desiccating from one side of the body over to the other, and just seeing a little bit of the different things that are happening through that. Now, this is just showing the simple pathways, and it's not really doing justice to the complexity of the brain. So we have to remember that even though we learn these pathways and we understand them and it's necessary for that, when we look at the brain from a healing perspective, we want to be thinking multidimensional. I'll show you some other diagrams here in a moment, but obviously those are the direct pathways. And if we go right up into the somatosensory cortex, looking at the body's homunculus, is organized obviously according to the body maps, and even within that there's greater organization there. But remembering we have a lot of territory, especially in the hands, the face, the eye, the mouth, the tongue. Those are really big territories, a lot of cortical representation. We really want to take advantage of those things. The other part of the somatosensory system that's a little bit underutilized is the proprioceptive organs, particularly our muscle spindles, as well as our Golgi 10 organs. So again, connecting into those, we can see that there's about one Golgi 10 organ per muscle. So that's perhaps, looking at, a variety of information there, but our muscle spindle fibers, of course, are highly utilized in every intrafusal fiber within the muscle itself. We're going to have a lot of the A1 and 2 afferent neurons. And again, looking a little bit at the pathway leading all the way, even from our joint receptors, our muscle spindles, what's going on to the skin, seeing how as they're working up through the spinal cord, up through the brainstem, having the cerebellum involved at this point now, and moving through that reticular formation, obviously going to the thalamus for higher level processing. We can see also on this diagram off to the right that the thalamus is the major integrative hub. Pretty much everything goes through there except smell. So it's a huge filter, and that's another key thing to be thinking about, that there is internal processing that's occurring. There are predictive pathways, error correcting pathways, filters beyond just the information we're providing. So there's a lot of things that we've got to be thinking about, because we literally sometimes are just operating in a black box. Once we send those signals up and in there, we're trying to figure out how is that all kind of going, and we're evaluating our outcomes. However, we're assessing those, and that's why it's so important to continue to assess those. How is that working? All right. So here again, just the sensory input is a network-wide aspect. We're really making sure that from bringing peripheral information in, a peripheral stimulation, it is literally going everywhere. And we know that the vestibular system is one of the first sense organs created very early on, 7 weeks in utero, and it has connections to everything and everything and everything. So again, super important that we continue to be thinking about how we can communicate at the network level, since we're having a hard time getting all the way up into that network level, right? So functional neurology, is this idea of looking at it as a network perturbation, and that literally really everything we already do in vestibular rehab, eye movements, balance, exercises, vibration, and cognitive training, they all are levels of perturbation. We just want to make sure that we can gauge that level of perturbation is a controlled enough challenge so that we are getting the appropriate neuroplastic event maybe happening at the molecular level that might not yet be seen all the way to the behavioral level, because that does take some time. I always say we're putting pennies in the piggy bank when we do exercises. We may not get those outcomes day one, week one, whatever the case is. I don't expect that, actually. I am looking to kind of shake it all up. And basically we have maladaptive neural pathways. We literally it's almost like sometimes when orthopedic surgeons have to almost refracture a bone that didn't heal quite right, for example, right? We've got to almost shake things up. That's pretty dramatic. We don't quite do it that dramatic, but in some level, we are literally trying to make those changes in that way. So again, I'm really just wanting you to kind of reframe your context of how you're looking at your neuro programs and maybe seeing it from a different lens in that perspective. So let's look at some clinical observations as we talked about. How does this look in practice? Well, again, if you're doing vestibular stimulation, visual, vibration, balance training, proprioceptive. So again, those muscle spindle, Golgi 10 organs, and wearable technologies. And so what I want to talk a little bit about today is just using something super simple, something easy you can easily implement. It has started to become a little bit of a game changer in my practice because I needed a tool that I can help patients with on more of a consistent basis beyond what I'm already doing. And again, looking at those billions of connections that are coming up into the brain, every second, what can I do to help create those neuroplastic changes on all those levels more consistently? So today I'm going to be talking about a particular product. I am an affiliate for that, but I'm not trying to over communicate about the product, just sharing what I use. So if it's something you're interested, you can always look into it for yourself. But I'd like to share the case that I was telling you about earlier on. So I'm going to show you a couple of videos. One video is when she would rotate her hand into more of a pronated response. That's when the tremor came. And but if she would instead of pronated, she'd be fine. Internally rotated, it would stop. But of course, if she had to hold her phone, she's gonna have to flip the hand up and to do that. And then that's when everything started. And then literally right after we put one of these sticky patches on, they're just small squares. They're wearable. They've got a little bit of like it's like braille for the brain. It's got a little code on it, so it's not just like a masking tape, which is smooth. There's just a little bit of communication there. So when I flip over to the side, the video is going to start. So I'm going to let you just watch that just a few seconds. And you can see here in real time that before having the super patch, which you can see on her thumb there, it's in red, that her hand would just continue to tremor. There'd be a moment of tremor there, right there at the very end, but then it subsided. And this was a huge win for her. We had already done a lot of work, and I'm sure we worked through all those 5 layers of neuroplastic changes and putting pennies in different buckets along the way, and they were adding up because she literally had a tremor completely on her whole right side of her body and a little bit over on the left. The right was the worst. So with doing a variety of work, we were able to correct her posture, her gait. We were able to quiet down the lower extremity, try to start to quiet down through the body. And last was really just the hand. It really just boiled down to just the hand, as you can see, the thumb. So it was very exciting to see that, being able to put a wearable on her, she was able to now just get control over that. And she didn't feel the inner urges for that activity to happen. All right, so a couple of other examples. This is just what kind of happened. Did we change the muscle? Did we change the strength? Did we change the basal ganglia? I don't know if we really made immediate changes to that level, but did we change the cortex? No, but we definitely changed the sensory, input. And so I think, here what may be happening, a lot of theories, lots of ideas, play with them, but definitely increase that somatosensory weighting where the brain's putting a little bit more weight, on certain input that's coming in, that's sort of facilitating, what might be happening in her, perhaps basal ganglia, allowing for the cortex and subcortical tissues to have more inhibition and quiet down that response. I want to just quickly show you a little bit of what a simple balance assessment is. This is a colleague of mine who is testing out this lady, and she's just basically doing a basic balance assessment. So I found with vestibular cases, and it's interesting how many people actually have a dysfunctional vestibular system, how easily you can just assess very quick is to do it before and then add the patch. It can, usually just be on the forearms and then retest. And you will see in very quick and real time that there's a change. I have found sometimes I might have to play with locations and the number of patches a little bit just to provide, again, maybe more input. But it's a nice way for patients to also see that their nervous system can change, especially when they've had problems and they've been chronic for a long period of time. So that's a little bit how that works. Some other cases I've used these in is an autonomic dysfunction. So again, seeing changes in the orthostatic tolerance, helping them not feel as dizzy upon standing, and assessing heart rate variability, looking at their blood pressure. Chronic pain has been another one where, again, just not putting the patch where the chronic pain is, putting it in other levels and areas. Also even seeing changes within neuroinflammatory conditions. Cognitive performance was actually a surprise to me. I was working with patients who we've worked them all the way up the ladder of skill set and into more memory, and adding one of the patches onto their skin. Now, mind you, I've also used other sensory related integrations. So percussive therapy, vibration, Resimax, a variety of other electrical stimulation and things too. So I'm sort of saying this as an add-on to some of that. So getting to a place where that wasn't turning the dial anymore, and finding that adding this, all of a sudden, some of the eye-hand coordination, timing coordinations that they had to do on the computer screen, they were just able to do, and normally it's a bit of a hot mess for them, and it can be quite challenging and uncomfortable. All of a sudden, they're like, boop, 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 and I literally, my jaw dropped. So we had to take it off and then put it back on and take it off. Anyways, obviously in concussion recovery is another good aspect depending on what neurological compromises they have. And another interesting finding was peripheral neuropathy. This is a series of patches that I've come to learn and apply. So it's not just one, it's a variety of different ones. But interesting because many patients obviously have peripheral neuropathy, which influences so many aspects of the whole neural access. And so just adding that series of 5 different patches, so it's like how we call the peripheral neuropathy kit in the office. That's just a made-up name we have, that helps people understand what that is. We've seen significant changes in their outcomes. Now, we're still monitoring to see if we're seeing changes at the peripheral neuropathy at the actual skin. Can they pick up on vibration better? Is there less pain and all those things? But neurologically, a lot of the function improved: balance, coordination, timing, cognitive performance, memory, with that. So that was very positive. And we see it from session to session, week by week, over a period of time. So some clinical pearls of things that I've seen patients who seem to respond well are definitely ones with sensory processing deficits. Vestibular function is also another key area. So definitely I would be targeting those patients, perhaps with something like that, where you're enhancing that somatosensory connection. So basically, just to wrap up here, if we're wanting to reshape a little bit of our neuroplastic events, improving brain optimization, and probably as clinicians having to correct maladaptive processes, let's start thinking a little bit of the network phenomena, where we have the ability to do neuroplastic changes on multiple levels and keep putting those pennies into those piggy banks. There's still a lot of theories and understandings of all the things that are occurring, but at some point, I think a lot of different things are happening for people at a lot of different levels. And if you're able to enhance even a fraction here, and all the different elements, we're going to make a cumulative amount of change. And then basically having the brain be able to start functioning much better, even on its own. So some of the clinical cases we discussed and things that we saw. And I think the biggest question here, just to wrap up and finish up, is, it's not really a question of can the brain change? We know that. We've been working with patients and seeing those changes in a variety of different cases, and every case is so unique and special. And we always learn something interesting from every patient. But I think now it's more about how can we make more strategic changes in a level that is, puts the patient also in a power position, the sense of more an empowered position, where they themselves know they can do things and they can see it in real time. So that has been a very exciting journey for me recently, and just as a clinical add-on. So if you have any questions, of course, you're always welcome to reach out. Happy to follow up if there's any additional things.
Dr. Habanova, thank you again for such a brilliant presentation. We always learn so much from you. I have lots of notes over here. I'm going to do a quick summary and then a couple of questions. So we were talking about the neuroplasticity problem. The brain is always changing, but sometimes the brain can learn the wrong lesson. You shared with us a great patient case, tremors and Parkinsonian-like presentation, how a wearable neurotechnology stopped the tremor immediately. Patients with chronic dizziness, lingering symptoms post-concussion, chronic pain patients, all examples of maladaptive neuroplasticity. With adaptive neuroplasticity, it promotes healing, recovery, learning something new, performance, things like stroke recovery and new skill acquisition. With maladaptive neuroplasticity, this can be from trauma, reinforced dysfunctional or harmful states, aberrant changes, chronic pain with altered signaling and reorganization of sensory pathways, for example, feeling pain without even a painful stimulus, persistent avoidant behaviors, and learned non-use, so forgetting about an affected limb by overusing the unaffected. So when the brain learns the wrong lesson with maladaptive neuroplasticity, we have increased GABAergic activity, disrupted synaptic turnover, overstimulation and neuroinflammation, and instability and compensatory network alterations. So the neuroplasticity shift, an emerging view, its neurorehab should view every intervention as a network perturbation, introducing a controlled challenge that forces the nervous system to reorganize. So perturbation to adaptive reorganization, and that perturbation being that controlled challenge for the nervous system to reorganize. And with neuroplasticity at multiple levels, from the molecular level, cellular level, circuit level, large-scale networks, and behavioral level. And the three pillars of brain recovery, we have error processing, so the brain learns from prediction errors, sensory context, vision, touch, proprioception, vestibular input, and excitability landscape, so the brain's readiness to change fluctuates between states of plasticity and resilience. So neuromodulation influences these states, and we can prime the brain for neuroplasticity. Challenge, context, and capacity all matter for neuroplasticity. And then we went through the somatosensory system. So going from the skin to the cortex, we have the dorsal column, medial, and meniscus pathways and the spinal thalamic tracts, and up to the body map, the sensory homunculus. Repetition and intensity, we need to keep providing sensory information. And our proprioceptive organs are muscle spindles and GTOs. The thalamus, a major integrative hub, relays and modulates everything except smell. And then sensory input is network wide. So for example, the vestibular system is one of the first systems created or developed in utero, and it's highly connected throughout. With functional neurology as network perturbations, those things like vestibular rehabilitation, eye movements, balance exercises, vibration, and cognitive training. And this matters because the brain is a dynamic network, so perturbation challenges the rigid or maladaptive pathways. And then in addition with clinical practice, adding wearable stimulation technologies. So you shared with us the Super Patch company, which is a wearable neuromodulation. It's a code for communication to the brain, and it's targeted tactile stimulation. And so with the network mechanisms, it increased somatosensory weighting, altered sensory motor integration, and temporary modulation of excitability. Also was effective for vestibular dysfunction change with the Super Patch. And you showed just such a great example with that tremor case. Thank you for sharing that video. And it also worked for autonomic dysfunction, chronic pain, neuroinflammatory conditions, cognitive performance, which is really cool, concussion recovery, peripheral neuropathy. And then clinical pearls, patients with sensory processing deficits and vestibular patients especially. And then looking at shaping brain optimization. So targeted sensory input, strategic network change leads to better outcomes and empower patients to see those changes in real time. And there's something very true about that. Seeing is believing. When they can see the change, they know that something has happened. I absolutely love this. Thank you for sharing this great resource with us. A couple of questions for you. Is this something that the patient leaves your office wearing and they wear it around the clock, or do they just wear it when they're having symptoms? How does that work?
Yeah, that's a really great question. I have actually started to integrate it, that it is something that I put on every patient now when they come into their neuro rehab sessions. I will do neurointensives, or I see people 2 or 3 times a week, depending if they live locally. So yes, they will purchase certain ones. There is a series of them. So certain ones do different things. So sometimes it is a little bit of a learning curve who needs what. But then I ask them to wear that for 24/7. So it's on one patch a day, take it off, and then put another patch on. Now, of course, if they're coming into the clinic for one of their neuro sessions, then they're going to get a patch from me. But I decided to add it into the sessions because I just see such better that time we can spend together is so much more powerful. And I've done it both ways where I was like, oh, you forgot, don't worry about it. It's okay. We won't do it today. Kind of like sort of testing that out. And then I realized they do need that. It is going to be, it has become an integral part of their care. So yes.
Amazing.
Yeah.
And so for the vestibular patients, you said that you've kind of played with exactly where to put the patches. Do you have any recommendations specifically for vestibular patients, maybe who are having dizziness, vertigo type symptoms, where to place those?
Exactly. Yeah. So again, very patient specific, depending on what you're sort of working on, and where you want more input, or is one side getting too much input. So again, we're trying to dampen down. Definitely anything closer up towards the head. I have, I know this is, you asked about vestibular. So a cervicogenic, cervical dystonia, excuse me, dystonic patient, I've been having it actually on their neck, and that's also helped to bring that back. Things further away, like in the lower extremity, obviously is not going to be as sort of powerful to the brain too. So I think there's that to consider, depending on the sensitivity of the patient and where you are in their neuro recovery and neuro fatigability. I did have an example with the patient where we literally can only put it on for a few minutes. It was valuable, and then take it off because too much was too much. And like any type of therapy, too much is obviously a neuro fatigue issue. So we had to really kind of dose that. But ultimately, it did become better and valuable, more valuable over time. But most patients can tolerate a full day and continuous, but everyone's unique and special. So,
For sure. Wonderful. Thank you so much again for sharing with us. As we wrap up another great session on the Virtual Neurology Summit, I'd like to acknowledge Dr. Habanova for her excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the postural neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.